Thank you so much, Allie. I'm Megan Hamilton. I am a director at the FPA, and I am what I call a TN mama. My daughter, Katie, was diagnosed with trigeminal neuralgia at 11 years old, and later with geniculate neuralgia also. We had to wade through so much decision-making about medications and doctors and many more doctors and new medications and surgical options, and ultimately 5 neurosurgeons before she had her second and successful MVD. She is now 7 years past that and doing very well. And I now head up also a group on Facebook for the parents of kids with trigeminal neuralgia and facial pain. So today we're going to talk about decision-making now that we've given you all of this information. And I'm joined today by Dr. Mark Linsky, who is the professor of neurosurgery at the University of California, Irvine, and by Dr. Richard Zimmerman, professor of neurosurgery at the Mayo Clinic. And our session is going to be a little different. We'll have a discussion together about how to do this and how to make decisions, what information you need, and things like that. So with no further ado, let's move on to some of our questions. We have everybody here. I see Dr. Zimmerman, but I don't see Dr. Linsky. Hello, Dr. Zimmerman. Thank you for joining us.
Hi, good morning or good afternoon, depending if you're on the East Coast or West Coast. But thank you for having me.
It's still morning for me. I guess it is afternoon for me. And do we have Dr. Linsky?
I'm here. I'm not sure why it's not showing up.
I don't know why I can't see you either, but I can hear you, so that part's good. Okay. Well, I'm going to
video button.
They get the camera thing fixed there for us. So my first question is, there's a lot of debate in the facial pain community about when to consider changing your treatment protocol, especially because neuralgia and related conditions can give you long stretches of remission where you don't have pain, or you might be well managed by medications. So do you stay there? Do you continue changing? And I wanted to get both of your opinions on that. Dr. Zimmerman, if you could start us off and let us know what you think.
Sure. Again, thank you so much for having me. I guess the first thing I would say is it's all about quality of life. So as you assess your condition, you're either stable or having exacerbations or are pain-free, you really have to think about, if I'm happy where I'm at, that may be good enough. And is the quality of my life what I want it to be? And is it impaired by my medical condition, by my facial pain? If you're okay and everything's copacetic and my management currently with whatever you have is good enough for you and you're happy, that's great. But if you're dissatisfied, and obviously if you're in pain, then it is time to consider a change. And no one's saying that you have to make a change or being forced into a change, and you still don't have to be forced into surgery. But if its quality of life is not where it really could be best, then I think it's a time to think about, do I have an option? Should I seek either a second opinion or go from what they recommended from one medicine to the next medicine, or do something differently, really have this surgery I've been putting off for a number of years, or because I'm afraid or because I don't know. And there are many pathways to changing this. There are second opinions. You may already have an expert professional that's helping you manage your pain, and then you talk to that person about changing. But it is the quality of life. I guess I'd try and summarize the answer into that level of assessment.
Yeah, I think that's a really good point. I know we had to look at that for our daughter when she was on medications when you're that young, and think about, is this working for her quality of life, and also long-term quality of life. And
exactly.
Dr. Linsky, can you also chime in with that?
Yeah, sure. We're trying to work on the technical issues with the video. So Megan, just repeat the question real fast, just to make sure I'm focused and specific.
Absolutely. Given the debate in the community about when do you consider changing your treatment protocol, especially because you can have periods of remission, you can be well managed by medications. When do you think about something else?
Well, I think the answer is very different for different individuals depending on their circumstances. If you're somebody who's near the end of your life and you're trying to make it to the finish line, that's a very different situation than somebody who's young and who is having problems with performance on the job and who's have problems learning or their education or setting their life track ahead of them, or even working in interpersonal relationships and developing them. Those are totally different circumstances. Somebody who is already had their education, has a stable social structure around them in terms of their life relationships, and is doing reasonably well on medication can certainly afford to go much longer than somebody who knows that this is a progressive syndrome, knows that this is going to fail, and is starting to have trouble moving forward with positive life choices and success. In those patients, they have to move forward sooner. I would also say that we have a couple other problems that patients have to seriously consider. One is that the people who are prescribing these medications initially generally tend to be neurologists, and that's fine because they're very experienced with these anticonvulsant medications. But the unfortunate problem is that most neurologists use these medications for a condition called epilepsy because they're seizure medicines. And the paradigm that they're taught in neurology for epilepsy is that you are not medically refractory until you've maxed out on a dose of at least 3 anticonvulsant medicines. And so the tendency is to just go medicine to medicine to medicine, cocktails, combinations, etc., because that's the paradigm that they're used to with epilepsy. There's no evidence whatsoever that that paradigm makes any sense for trigeminal neuralgia. In fact, I would agree with Dr. Brown earlier today when he said that if you have one main frontline treatment, Tegretol, Trileptal, Neurontin, or pregabalin, and you've been able to get to an adequate dose without toxicity or side effects, and you fail, there's very little to be gained by adding additional agents, switching agents, going to longer acting agents. It's time to make a change and decide what's going on, what's best for you. The other thing I'll point out with these medicines is their effects on you are incremental. You keep increasing the dose a little bit by a little bit by a little bit, and you don't realize how severely you're being affected because you're no longer comparing against yourself before you started the medicines. You're comparing against yourself how you were on the last dose. And as that starts to happen, you don't quite realize how much of a fog you're in and how much your judgment and thinking and memory and learning and focus and concentration are starting to be impaired. And this creeps up on you. And I'm sure Dr. Zimmerman would agree, most patients, once you get them pain-free after surgery, if you're able to do it, and they get off their medicine, will tell you when they come back to the office, I had no idea had no idea how much these medicines were affecting me. I sure wish I had done this sooner. Does that answer your question?
Absolutely, yeah, and have to agree from a home point of view. Honestly, our daughter was 11 when she was diagnosed, and almost 14 when she was finally pain-free and off medications. And I thought she had just been going through teenage years. And when she started really cutting off the medication, all of this personality came back, and talkativeness and hyperness and happiness that hadn't been there. And I realized that was a really big hindrance for her. It was a big difference. So I think you're absolutely right on the medication.
Megan, I'm going to log out and try to log in again and see if I can reconnect the video. So I'll be back.
Absolutely. We're going to keep going, but we'll bring you back in. Okay. Our next question is, if I come to you, Dr. Zimmerman, as a patient, and I'm discussing with you the possibility of surgery, how can I best be prepared to help you help me? What is it that I can come in the door ready to talk about with information or whatever to present to you so that you can best help me?
Well, I think the first thing I would say is let me understand well how this is affecting you, and tell me the experience you're having with this and how much it's impacting your life. Because the most important thing the first time you come in the door is we have to confirm that it's the right diagnosis. We do need to know that it is TN and not a different type of facial pain syndrome or craniofacial headache syndrome. But assuming it is TN, and whether it be TN1 or TN type 2, you have to feel confident that the person you're talking to about surgery is a surgical expert. Because one of the biggest problems you'll have is you'll go to someone to talk about surgery, but that patient does, quote, cranial surgery, or they do it. I do MBDs, so to speak, and I'll put that in quotes, because many neurosurgeons are, quote unquote, trained to do MBDs. That does not mean that they're a specialist in MBDs. So in preparing yourself to help me help you, I would suggest to you that you make sure you go to someone who is well-versed in trigeminal neuralgia, the scope of the disease, the time course of the disease, how it impacts the patients. And then obviously for all surgical issues, you want to go to someone who's an expert. You don't want to put someone who's finished flight school into the space shuttle for their first flight. If it was your brain, you wouldn't want this to be the person's first MBD of the century. Oh yeah, I've graduated, I trained, and I did a lot of MBDs, and here's my first one on my own. You really should see someone who is qualified as an expert, who, for lack of a better term, has a good reputation, who has had good outcomes that other patients can, quote unquote, attest to. And resources like the FPA, TNA is a great place to find experts. Preparing yourself to help me help you is for you to be knowledgeable about those things. Once you get to that stage and you're at the door of someone who is well-versed in treating trigeminal neuralgia and you're looking at surgery, be prepared to ask questions and have them answered. If someone says, oh, I have 15 minutes to spend with you, you have TN, I see the vessel here, it's time for surgery, I'll book you on Tuesday, it's time to walk out the door, because honestly, we see patients who have their surgery scheduled before they're interviewed in places that simply want to get the surgery done and go on. And that's not the way to take care of someone who's been suffering with this condition and facial pain. So prepare yourself by being ready to ask questions, simple questions about the surgery, the surgeon's experience. What should you expect from surgery? What kind of a discomfort am I going to have after the surgery? What's my recovery going to be like? How long will I be in the hospital? If you can't get answers to all your questions and your family members can't get answers to their questions, then it's time to keep looking. In getting back to what can you do, I would say prepare your questions. And there's Dr. Linsky.
There he is. We got him back.
I regret it, but I'm here.
Woo!
Hi, Dr. Zimmerman. Good to see you.
Hey, Mark. How are you?
Okay. Well, Dr. Linsky, let me pose the same question that Dr. Zimmerman just answered for us, which is, if I come to you to discuss the possibility of surgery, how can I be best prepared coming in the door to help you help me? What information do you want? What can I do to make that the most productive I can?
Well, first of all, if you've had procedures before, it's very important to collect the reports of those procedures so that they can be reviewed. Saying that you've had a prior MBD, saying that you've had a prior gamma knife, whatever, they're not all equivalent. And in particular for MBDs, you need to be able to read and see what the other doctor did and what they saw and what they found and even how they closed up, things like that. So details of the procedures are really important. I like to have a patient have a cranial nerve protocol MR done, which is it's already been described in the earlier talks, volumetric T2 acquisition with submillimeter slicing, and that, depending on the machine, can be called a KISS, a Fiesta, a fast spin echo, depending on whether it's a Philips, GE, or Siemens for the machine that's doing it. That helps tremendously. But really what it boils down to is an understanding of the patient's circumstances and their life goals. I mean, what is their family relationship? What do they see as their timeline of wanting to have control of this going forward? What is the impact of the disease and the medications having on their job performance, depending on what they do and what their goals are for that? What is its impact on their relationship with their spouse, with their children? What risks are they willing to take given the fact that they are often part of a social unit? And they're not making decisions just for themselves. They're making decisions for their families. They're making decisions for their spouse. They're making decisions for their children. And you need to put that in proper perspective, because there's no one size fits all, and there's no one treatment recommendation that works for everybody. There's a right answer for you, given your own goals, priorities, and your own risk assessment and risk tolerance. what I often tell patients is that there's no such thing as a course that choosing between a course that's safe and a course that's risky. Every single course ahead of you carries risk. And for a progressive syndrome like trigeminal neuralgia, doing nothing, depending on how young you are and how it's affecting your life, could be the riskiest choice of all. But people also tremendously differ in their risk tolerance. I like to use the analogy of money. Some people will only put their money under the mattress. Some will bury it in the backyard in a coffee can. Some are willing to put it in a savings account, but only up to the FDIC insured amount. If not, they're moving it to the overflow to another bank. Some will go into the stock market, but only in balanced mutual funds. Some will invest individually in stocks. Some go on to junk bonds and things like that. Everybody's risk tolerance is different, but the money analogy also goes well in understanding the benefits for a given level of risk. Open surgery with anesthesia, hospitalization, recovery, and risks also carries the greatest possible, both short-term, immediate in the recovery room, and long-term for the rest of your life benefit. So when you're going to get to the point where you're ready for surgery, it's going to be an individual choice. Dr. Janetta told me during my 7 years with him is that you never want to talk a patient into surgery. They'll know when they're ready. Just make sure that they understand what's going on. And that, I think, weighs into another critical thing. The time to talk to a surgeon about the options you might have for surgery is not when you're in extremis, in desperate, in severe pain. It's not when you're overwhelmed with the medicines and you can't remember what you just heard, you can't learn, you can't focus, and you're falling asleep in the doctor's office. It's like estate planning. You know, the time to do it is early in your life, so that when you get to the end of your life, or in this case, to the time when you're ready for surgery, you already have your plan laid out, and it's just a matter of implementation and pulling the trigger. So see a surgeon early. You're not committing to surgery. You're getting information, and there's no downside to information. And getting that information when you can best understand it, best put it in perspective, and best fit it in a non-time compressed manner to your life planning is the time to do it.
Right. And for full disclosure, Dr. Linsky is the one who did my daughter's second MBD. And I don't know if he remembers this, but we came to him very informational. We want to talk to you about this. And at the end, we're like, we're going to go home and talk about it more. And only called back later to say, yes, we're going to do this in 2 months, you know, because that's what was going to work for our family. And we were in a place that we could do that because her pain was still pretty much managed with medication. We didn't have to make an urgent decision right now to fix this right this very moment. And I think that was really important for our own peace of mind in proceeding with what we were doing too. We could be very well thought out and reasoned and take a deep breath before we jumped into that. Dr. Zimmerman, do you have anything to add?
No, I think it's pretty much right on the same wavelength as Dr. Linsky. I mean, it's just like if you're taking medication for anything, you don't want to wait till the medicines run out and you're going to call for a refill and expect to get a response and a refill immediately. You don't want to wait for the last minute to decide you need surgery because now you're suffering and the medicine's not working. It is always a good time to know all your options. The better educated you are about your condition, the better educated the family is about the condition that you have, the better you can make good decisions and good choices. And certainly, I think all of us, since we feel that there is a cure for this condition, not a management protocol, which is medication, but a cure to stop the condition with surgery. I think a lot of us, obviously, the surgeons have an admitted bias, but when we feel that there's a cure as opposed to a management option, we think that you should consider the cure early on.
Wonderful. Yeah, I agree for my daughter, at least. And also, I wanted to put in there, when you're going in to have this first consult with neurosurgeons, it can be really intimidating as a layperson to walk in there and be getting all of this information about subjects you previously knew absolutely nothing about. And I came in with lists of questions, and Dr. Linsky can vouch for this. I would always come in with my notebook and many questions, many questions listed out, and be asking them one after another and taking notes. And I liked having, anytime I could, have someone else there with me to make sure they were catching the pieces that I might not be catching. We could all talk about it afterwards, my friend and I, in order to, or my husband, in order to kind of like, did you get that too? Did you understand what he was saying there? Did we both understand that the same way? So I think that's a really valuable thing to do for anybody considering these surgeries.
Yeah, I think that's an important point to make, both what Mark had said and what you just said. It's even more so if the patient is already taking medications, they are impaired to the ability to recall and comprehend what's being discussed. Even if they take notes, maybe in a fog. So have an advocate with you. Patient advocacy becomes extremely important for any surgical procedure because during your recovery, during your transportation, during your management of anxiety, and so many aspects are surrounded by the support system that you have. So having someone to take those notes for you, if you're the patient with the condition who's on the medications, you're not really necessarily always all there. So to taking those notes, ask those questions with someone who can help you.
Absolutely.
Two very good points, Megan. The first is that studies have shown that the stress of being in a physician's office, even if you're not on medication, let's say for surgical consents, that the average patient only remembers 50% of what they're told. So having a second person there with an additional accessory RAM to help remember is exceedingly important. And in fact, for consents, I insist upon it. The other thing is that a good consult, you'll know you're talking to a surgeon or even a non-surgeon dealing with trigeminal neuralgia. If your first consultation is like going to class, it really needs to be an educational session. And it can't just be them saying, I know what you've got and this is what you should do. It should be laying out what the natural history and the pathophysiology of this condition are, linking it to your circumstances, goals, and priorities, and then in a rational, organized, schematic way, going over the options. We also make sure that every single patient at their first visit is fully connected with all the information that we value that's out there. So some of them come to us because they were sent by their doctor or their insurance company. Some come because they were on a Facebook support group, but not everybody is necessarily connected with the national nonprofit organization in Gainesville. Not everybody has had access to their literature in terms of paperback publications. Not everybody knows that we have a face-to-face Orange County support group if you don't like Facebook and you want to be face-to-face in our county. So we make sure that they're all connected and hooked into those things. And then finally, you'll find that the most expert physicians dealing with this have a team around them, and that's there for many reasons. But one of them is you don't want to necessarily dominate your time with the physician taking on all the basic information. You want that basic information to be able to already be done and present before the physician comes in so that you can really focus on what's really important, the education, the counseling part of the visit, rather than having the doctors asking you what your allergies are and what surgical procedures you've had and what your past medical history is, et cetera, and so forth. And Dr. Zimmerman, I'm sure, has it set up the same way I do. My PA's been with me for over 5 years and probably knows more about trigeminal neuralgia than most board-certified neurosurgeons. And my nurse coordinator has been handling the phone as well as coordinating the care and the testing for my patients for 8 years. And these are invaluable pieces that need to be there for you to be able to focus and spend your time on the quality issues with the consultant.
Mm-hmm. Absolutely. We have come to really rely on and enjoy your staff because we often wind up talking to them. And I think that's wonderful when doctors build that around them. It helps a lot.
Absolutely true. And Mark, to the point of having a team around you, the other aspect that's a good question for patients to ask is, what is your protocol? How have you set up special care for your TN patients? So whether you have a team around you, like you said, allied practitioners, advanced practitioners that know about TN, that can answer a lot of questions. What do the nursing staff on the floor know about TN? How educated is your floor unit for taking care of these patients and managing them safely in the hospital and getting them in and out effectively, efficiently, and safely? The team approach is extremely important to good care of the patient. Their hospitalization is such a brief period of the time that they spend suffering with disease and searching out the answers. But that's probably the most critical point, is to make the right decision, to be informed well with some support system around you. but have the team that's available from the healthcare provider. So when you do have questions or when problems do arise, there's always someone there available. There's not one person that's going to be always available. But if you build a team around the program that you have for trigeminal neuralgia, then there's always someone that can answer something about it. Even if it's not a primary member of your team, all of our staff, the PAs, know the trigeminal neuralgia practice well. And therefore, it pretty much doesn't make a difference when you call about tapering your medications, coming off of them after surgery, surgical wound care. It really makes a big difference that there is a system built around your trigeminal neuralgia practice.
Absolutely. Absolutely. And I also wanted to mention for those who are watching that before into the doctor's office, I had done a lot of reading. I think it's one of the wonderful things about the FPA is the website, the articles that are available. And so I had some knowledge of the terminology that was going to come out. I had some basic knowledge. And so I just really encourage that too for anyone who is going into these appointments to go learn some of this stuff, get familiar with it. It really does help. I want to ask you, one of the things that we struggled with is we had some doctors who were telling us, no, surgery is not an option. Others saying, yes, it is, absolutely. Or some would say, well, I'm willing to try. And we very much encourage at the FPA people to get a second opinion. But what do you do when you get two opinions that don't agree or more that don't agree? How should the patient approach that in their decision making?
Well, the first thing is that you really shouldn't be having a non-surgical surgery is not an option. That's rather somewhat arrogant for that person. You really need to talk to a surgeon about that, and one that's very experienced in doing these sort of things. That being said, it is certainly possible and highly likely that good, well-trained, good, smart surgeons who are not bad people, who are trying to do the best for you, can legitimately disagree. And that's fine. What you need to understand is, why do you believe what you believe or say what you're saying? What are the reasons behind it? And then research the reasons behind it, and don't be afraid to get additional opinions. You don't necessarily want to be searching out the person who says what you want them to say, because then you're going to have your surgery done by somebody who does one of these every 3-4 years, who says they have a 100% success rate and have no complications. And that may be what you want to hear, but that's not very likely if that's the circumstances of the surgeon. But you need to be able to understand the reasons for what they're telling you, and then hear it from several other people and address those same data points that they're focused on and see what their perspective is. You've heard some stuff this morning that, quite frankly, I'm sure Dr. Zimmerman and I disagree with from some of our colleagues that gave presentations this morning. That doesn't mean that they're right and we're wrong, or that I'm right and Dr. Zimmerman's wrong. For example, I'm very sad to see people thinking that MRI has progressed to the point where we can decide whether or not vascular compression is present only based on an MRI. I couldn't disagree with that more. I think Dr. Janetta would roll over in his grave if he heard anybody say that. But the truth of the matter is that well-intentioned, well-trained, smart people can honestly disagree. And you've got to also keep in mind a couple of other things. Number one, doctors go into either surgery or non-surgery sometimes for, and one of the reasons is that people who don't go into surgery aren't necessarily interested in surgery, or they feel almost a paternalistic feeling towards their patients. And there's sometimes creeps into this relationship a natural tendency that has to be constantly resisted to say that, or to think that they're somehow there to protect their patients from the surgeon. Because surgery can be risky. Surgery can, lead to complications. Surgery is invasive. Surgery has anesthesia. Surgery involves cutting tissue. But the truth of the matter is, if the cure, as opposed to just the management of a condition, is surgery, then the surgeon is exactly who's needed. And you ideally want to get involved in a group of doctors, both surgeons and non-surgeons, who are working together collaboratively. So you don't have that sort of competitive or adversarial sort of approach. You have them supporting one another and understanding what each other's roles are in the overall treatment of a patient. And I think that's very important.
Absolutely. How about you, Dr. Zimmerman? What are your thoughts?
So, I mean, there's so much agreement between Dr. Linsky and myself, even though at times we do disagree. But the thing, and I know there are patients that we've shared that we have two different opinions of at the time. And sometimes it's the way the patient presents their syndrome or their pain or their satisfaction with current management that will make the recommendations of the surgeon vary. And as Dr. Linsky said, when there are two, and even if there are 2, 3, or 4 different experts, even on the MAB, there are times when we have a little bit different perspectives of what's the best thing or the right thing to do. I think clearly one of the things is that Dr. Linsky mentioned that I had started to talk about earlier, the issue and the distinction between management of your medical condition and a cure from disease are very divergent points. And if you could be cured of cancer, you probably prefer that as opposed to managing your cancer with chemotherapy on an ongoing basis. I'd rather be one and done and have my cancer gone than have to always be vigilant about taking my medication. Otherwise, it's going to come back. I view trigeminal neuralgia the same way. And from a standpoint of when people interview me and ask, why do you find the care of these patients so rewarding? I said, because it's really a very different perspective. It's a life-changing event. When you take a condition or disease that the patient's been told this is chronic, you'll have this the rest of your life, and it's a chronic condition, a chronic medical condition, which is a class of medical conditions in of itself. And you get to change their understanding, the perspective, and the reality for them that, no, this is not a chronic condition. This is a condition that can be cured, and you will be free of disease, or potentially free of disease, because nothing is 100%. But you offer them a cure of a condition. That is a dramatic change. So there's someone that says you're not a candidate for surgery. There may be some good reasons for that. But if you haven't had a real appropriate surgical evaluation, you haven't been given the opportunity for a cure. You haven't been understand that perspective of management versus cure. There's a gap in what's been provided to you as the patient is information. And you should really understand that real situational experience of, I make a decision now to manage my problem, or I make a decision to potentially get rid of my problem. And I think that really needs to be better understood, because there's so much discussion about trying to manage TN. And certainly it's not, no one's going to say that surgery is 100% cure. No one. None of the surgeons will say that. But the real understanding needs to be that there is an option for cure. There is an option of a pain-free life without depending on medication, without being in a fog. And I just hope that more people understand that. And, surgery and rhizotomies are an avenue that gets there as well, although I'm not sure that many of us would say that's the best option to get rid of the condition, because we like to get rid of the condition without losing any function at all, without damaging any neural tissue. As neurosurgeons, we spend our lives preserving everything possible. But certain options are better for some patients than others. That's fine. But again, the distinction between freedom from disease and managing your disease are very divergent points in a patient's decision-making. And those that support them have to understand that. So I think, in those discussions, when you see differences of opinions, it's okay, you'll get them, but try and understand the perspective of, is there an option for cure, or am I being led down the path of, you're going to be left with this and manage this?
I would be aware of 3 specific reasons a doctor says you're not a candidate. Beware of somebody who says you're not a candidate because your MR ruled out vascular compression as a cause of your syndrome. I think that's false, and I think that has been a huge disservice to a ton of our patients. Number 2, you have to be very careful about saying you're not a candidate for an MVD because you're too old. The truth of the matter is, it's not the years, it's the miles, as Indiana Jones said in the Raiders of the Lost Ark. There are patients that when I was at the University of Arkansas, who were age 40 or 50, who I would never operate on. But in California, there are 80-year-old patients who play tennis every day, aren't on a prescription med, and are healthy as a horse, who I wouldn't hesitate. The issue is cardiovascular risk factors, not age. And finally, you have to make sure that you understand the difference in expectations and outcome between typical neuralgic pain, which is sudden, sharp, stabbing, brief, lancinating electric shock-like pain with no pain between episodes, and atypical neuralgic pain, pain that is dull, aching, throbbing, burning, pressure, whether it's episodic or constant. To say that the atypical component of your pain is not something that can be helped is wrong. The expectation, however, has to be very different. The measurement for success for typical neuralgic pain after a surgical intervention is black and white, pain-free. It's like being pregnant. There's no such thing as a little bit. But when it comes to atypical neuralgic pain, the endpoint that is realistic and is honest is not pain-free. It is the endpoint we use for clinical drug trials for trigeminal neuralgia, namely a 50% improvement in the frequency and the severity of your pain. And while for an MVD, let's say, in proper hands, the chances of achieving the endpoint for typical neuralgic pain is 80% in proper hands, for atypical neuralgic pain, at best, that's about a 50% chance. So a 50% chance of a 50% improvement in the frequency and severity of the pain, meaning taking it from a 10 out of 10 before the procedure to a 5 out of 10 or less. To say that that is not a valuable or worthwhile endpoint for a patient and that they are therefore not a candidate for surgical intervention shows a severe misunderstanding of what patients will necessarily themselves call a success. I've had many patients with atypical neuralgic pain or hybrid syndrome say that if you can get it down to 50% and I can reduce these medications doses that I'm taking, that may not be a home run, but that's a triple. Thank you. I don't mind.
Yeah, I think it's so important. First, two things that were said here. One is that very good, very compassionate doctors can have differing opinions on how this should be done. And it's one of the reasons it's so important to talk to more than one. And also that you should go in and be asking these questions of your doctors and specifically wanting to know, why is this the best decision as opposed to that? Like, ask those questions to help yourself know that you are comfortable with what the answers are that you're given. I'm going to end with one last question. We only have a couple of minutes here. My last question is, okay, I've gotten to the point that I know I want to have this surgery and I have decided on that. How do I decide the surgeon I should go to? And I know that I should decide each of you because you're the best, but when I'm walking in to see a surgeon, how do I evaluate that and decide, yes, this is a person that should be doing my surgery for me, or no, this is definitely someone I should not be going to?
Well,
go ahead, Lindsay.
There's a chapter in this book on that, as well as an article in the spring 2015 quarterly on that, where we sort of lay out what those features are, at least for MVD. So in my opinion, that surgeon has to have been trained by a master in the technique, to have learned all the tricks, to have learned all the ways to get out of trouble and all the variations that you can find in there at surgery. They need to be over their learning curve and not learning on you. And in my case, that's about 50 cases under your belt after you're done training. They need to be doing a minimum volume per year to keep their success rate up and their complication rate low, and using crude Medicare inpatient data samples, only looking at discharge to other than home or death, which means severe disability or death. The minimum number is somewhere between 6 and 12 cases per year, and there aren't many neurosurgeons that are board certified in the U.S. who are doing 6 to 12 MVDs per year. This is a rare condition. Finally, in my opinion, or second last, in my opinion, they should only be doing this operation with intraoperative AVR monitoring, which lowers your hearing risk by 50%. They should be ideally surrounded, as Dr. Zimmerman and I have already talked about, with all the other pieces in the puzzle necessary to optimize your outcome. Neuroanesthesia, the personnel in your clinic, a dedicated neuro ICU, the neuro monitoring techs at surgery, the neurotechs handling the Teflon and the equipment, the dedicated neuro nurses, not just general med surgical nurses in the neuro ICU to have your result. And this is somewhat of an academic bias, so take it with a grain of salt. But I really do think that your best results are going to be with a surgeon who doesn't stop following you after your 90-day global, that are following you long-term, assessing their outcomes long-term so that they know whether what they're telling you is reality checked against what their real results are going forward. And those are the key features that I would think. And I'd be very interested in what Dr. Zimmerman thought.
Absolutely. Dr. Zimmerman?
So many of the same things. I think when the patient calls, how do you discern that this is an experienced and very advanced surgeon with regard to TN management and TN surgery? A lot of word of mouth is, word of mouth from other patients. And I think the support groups are very helpful. FPA, TNA, the Facebook support group and other groups out there are good because you get a preponderance of people that have had a good experience. And I think that's a fairly unbiased. Obviously, that patients that don't have a good outcome sometimes tend to be more vocal and loud, and the patients that are very successful with their outcomes tend to say, I've gotten rid of my disease. I disappear from that world. But the other thing is the questions you ask as a patient, see what the team says. So if you want to talk to the allied health staff, because frequently when you call, you won't get the surgeon at the other end of your line. You'll get an office staff person, you'll get an advanced practitioner, NP or PA, and you can ask them about the practice. So they say, oh, we haven't done one of those, or we don't have anything special for those patients, so there's not really a protocol. If you ask about a protocol, what's the system you have for TN patients? How do you manage them? Do you have a special MRI available? A lot of that question asking that you mentioned up front when you come with your notebook is the way that you decide this is a systematic approach to trigeminal neuralgia in this institution. Because while the surgical skill is one measure, an indirect measure of that surgeon's skill is the reflection that you get from the rest of the institution, the nurses, the staff that are there. When you see that system is in place, you know that surgeon likely has a busy practice in trigeminal neuralgia and has organized their practice to focus on the care of these patients because they are a concentration in this individual's world. They don't do, well, I do brain tumors, and I do trigeminal neuralgia, and I do endoscopic surgery, and I do microscopic surgery, and I do minimally invasive surgery, and I can do a few fusions in the spine when I have time. A busy surgeon is not always the best person to go to. A surgeon who's busy and specializes in the area of your condition is a better advantage. And I think the questions you talk about that you bring in your notebook and the assessment you get, because many times you'll go to the office and call them on the phone, or the first interaction you'll have in the office is with someone else on the team besides the surgeon. Or after that, planning for surgery, scheduling of surgery. If they answer all your questions with clarity and with consistency, in other words, you ask the question, you may ask it again, you get the same answer. That's very important. When you get inconsistency, it's very frustrating and can be very disconcerting to say, they said there's nothing special, and then someone else said, oh, we do this all the time. Well, the last person I talked to said we don't do them at all. No, we've done one like last year. So you really have to listen and think critically about the answers and information you're getting.